So what's coming up in this episode?
So as my role is, it's that transitioning from oncology back into the surgical world. I take that role with our group to make sure the patient's educated on what to expect.
Sounds like you're the glue in this MDT.
I'm just the safety net.
Yeah, I think the key is you have to have a clear path for the patient with a plan. And so when we kind of talk to the patient and we talk about neoadjuvant chemotherapy, we give them a calendar and we ask them, this is what it's going to look like with the chemotherapy and immunotherapy treatments. This is when we're going to finish treatment. And this is where we're going to start scheduling a follow-up with Dr. J. Ram or one of the urologists.
As a very busy cystectomy surgeon, I can tell you that there are a lot of patients who come to me and the first thing they say is, I'm not having my bladder out. And that's an important part of the discussion because then we talk about quality of life and we talk about reasons why. And some of those patients end up saying, okay, well, if it makes sense, we'll do it. But fundamentally, it is such a big operation that patients need to be involved.
Hello and welcome to this AMJ podcast entitled Inside the MDT, Expert Voices in Muscle-Invasive Bladder Cancer Care. I'm your host, Sue Saville, and delighted to welcome our three experts representing different clinical perspectives, an oncologist, a urologist, and an advanced practice provider, or APP. So we have with us Dr. Chandler Park, who's a medical oncologist at the Norton Cancer Institute and clinical faculty, University of Louisville School of Medicine. Also, Dr. Tam Jairam, urologist at Urology Associates in Nashville, Tennessee. And Michael White, physician assistant, Urology Partners of North Texas, who will tell us about the role of advanced practice providers. Welcome to you all.
Hello.
Yeah, great to be here, Sue.
So firstly, let's discuss multidisciplinary team collaboration and best practices. Dr. Chandler Park, firstly, are both urologists and medical oncologists part of the tumor board and involved in treatment discussions at your institution?
Yes, Sue, absolutely. I practice in Louisville, Kentucky, 16th largest city in the U.S. And so we have a very large urology group, friends with a lot of people in the group, about 44 urologists. And I'm part of a big medical oncology group, about 35 medical oncologists. And there's three of us that focus on GU. And so every week I go to the urology clinic at First Urology in Louisville, and I work together with the urologist there and see the patients in a prospective manner. And we also have a multidisciplinary tumor board. We talk about patients in a prospective fashion. So now I'm very lucky to be where I'm at right now.
That sounds good. What about Dr. Tam Jairam, or Tam, if I may? How involved are urologists and medical oncologists where you are?
Yeah, I would say that it's probably the most important part of dealing with muscle-invasive bladder cancer. 20 to 25% of patients with bladder cancer present with muscle-invasive disease. The vast majority of bladder cancer-related death is attributable to this group of patients. So it's a very serious disease state, and it's increasingly becoming a disease state where you need to have a full toolbox, if you will. So fundamentally, a very important collaboration. As a urologic oncologist, I see a whole lot of bladder cancer, but only a small percentage of these patients have muscle invasive disease on presentation. And that group of patients has an extremely high proportion of metastasis and death related to bladder cancer. So this is a very dangerous disease state. And now increasingly, we're understanding the benefits of multimodal therapy for this group of patients. So we have a multidisciplinary tumor board. We have 2 to 3 GU versed or GU inclined medical oncologists who are very, very interested in the data. We run clinical trials together, and we do a lot of things to help support our patients. So it's fundamentally probably the most important disease space, in my opinion, to have good multidisciplinary collaboration.
And there are other roles, the advanced practice providers. Michael White, in your role there, how are you integrated into those multidisciplinary team meetings? What value does an APP or a PA bring in terms of decision making and that continuity of care?
Sure. So I think the big thing is for an APP and their role in this space is the fact of continuity of care, making sure that patient is being handled, whether it's being, sent to the oncology team from the urology team, making sure that everything continuity is being delivered appropriately. And then also making sure that the patient, when they come back to the urology team before they go into an operative setting, that we've got everything covered from the oncology side moving forward. So.
And there are, of course, other disciplines. I'm wondering, Dr. Park, do radiologists, pathologists, the radiation oncology specialists, what do they contribute to your MDTs?
Yeah, it's like a basketball team, right? All of these different providers play a role. And, I used to be a radiology resident. So when I used to look at scans, there's so many images between the chest down to the pelvis. And when I see the patient and I know what the decision points are, for instance, is a patient a candidate for radical cystectomy based upon whether they have a periaortic lymph node versus a common iliac lymph node or just an internal iliac lymph node? So I push the radiologist or multidisciplinary clinic and say, does this lymph node look like it's in the periaortic or common iliac? And they give us that, instant reaction. They look at the lymph nodes. In terms of the pathology, they're not 100% urothelial. Some of these patients are predominantly squamous. If they're 100% squamous, maybe we have to do cystectomy first. Or if they have, small cell variant. And so we kind of push the pathologist and say, okay, is this a variant histology? And they kind of give us the answer. And then in terms of the radiation oncology, right? Very rarely, if a patient has a solitary node, no CIS, no lesions that's caused in hydronephrosis, and they're like medically unfit for surgery, maybe they can get radiation treatment. So they all play a role and we all work together as a team.
It all sounds very smooth. I'm wondering if that's always the case. Dr. Jairam, do you encounter any challenges with the collaboration of cross specialties? And if so, what are the best practices for collaboration to overcome the challenges?
Well, I mean, the challenge is fundamentally we're not all under one roof, and that causes some uh, difficulty. We really try to mimic our academic colleagues in terms of offering kind of this full gamut of services, but logistically it can be challenging because patients have multiple appointments. They're coming from far away. But really, the important thing is to identify the key stakeholders in the team and to start forming relationships, and to understand that it's really the strength of the entire team that I think pulls the outcome forward. Dr. Park mentioned pathology, incredibly important in bladder cancer. Being in downtown Nashville, we get a lot of referrals from rural Tennessee, second opinion cases. The pathology is incredibly disparate between low volume sites and high volume sites. And it could mean the difference between someone keeping their bladder and losing their bladder. So, really important to engage the stakeholders. We have dedicated GU pathologists that I can call, in a few minutes and get an answer back to say, hey, can you look at this again? I'm wondering, what percentage of this was variant? Is there lymphovascular invasion here? What do we think about this? And the same with radiologists. All of it makes the machine go. So I think there are always going to be some logistical challenges when you're in the community setting, because not all health systems are kind of built the same. But it makes it even more important to develop those deep relationships between the providers.
And is that the case, Michael White, for you in your role? Do you see challenges that you have to navigate in the MDTs?
Sure. I mean, I think, like both physicians have said, I mean, it's a teamwork approach. I mean, you have to have all hands on deck, especially with the bladder cancer patients, because when you have a bladder, cancer that's muscle invasive and these patients are not being followed appropriately, you've got to have that team approach to where we're relying on the services to be joined in together. So that's where I said, it's important to make sure you have the relationship with the oncology services and the pathology. We have our own radiation oncologist here within our group. So that direct referral, making sure, and I use the APPs as kind of a sounding block where I can call in and make sure that patient is being followed up within the week. And so we don't have those hiccups in between treatments. So the modality is very, very important between transitioning of care.
So looking a bit more then at that patient pathway and that coordination you've been talking about, Dr. Park, what does that patient transition look like from from the urologist to your medical oncologist? What's it like for you?
Yeah, I think it starts building relationships with our urology colleagues, having a lot of friends where you're readily available. I think that's the key. If somebody's calling you or texting you, they need some information right there. And so when you build that relationship and you're available, then once you have a new patient, it's just kind of like getting the patient in your clinic as soon as you can. And so if I get a phone call, I try to get that person in like 2 or 3 days, the next business day, as soon as I can, because patients are scared. We want to get the ball rolling. So the patient transition is one of the urologists maybe calls me or sends me a referral. They come to my clinic and I'm just kind of, evaluating everything, looking at the notes, trusting my providers and seeing, and I have a nurse practitioner with me. So we see the patient on the first day and I introduced him and say, okay, this is my advanced practitioner. There'll be some days where I might see you in the chemo infusion area. You're going to see this person. They're part of our team. And so by doing that, it allows the patient and their family members to know that, yes, Dr. Park is here, but a team member is also here. He's going to let Dr. Park know. And so that's a good way of kind of getting the ball started.
And from the urologist perspective, Dr. Jarob, how do you initiate that transition?
Yeah, I would echo what Dr. Park said. I think the nice thing here is we're kind of all set up for success because we refer to each other. We kind of set the stage to say, well, this is the person you want to see. This is the person that does the most of these, and that helps build confidence. And I think that's really important. I have a very large, impressive academic center, 3 miles, 5 miles from where I practice. And I think a big reason we don't necessarily see a lot of patient attrition or losing patients to those centers is because of constant communication and the repetition of, like Dr. Park said, contacting patients and saying, "Hey, we talked about you at Tumor Board. We had 5 or 6 really smart people look at your case and weigh in, and this is what they thought was the best treatment." And patients really, really respond to that, right? You're not in an isolated silo making a decision. You're coming in with a built-in kind of group opinion, and for community health systems, that's really important, especially when it comes to complex decision making in disease states like muscle invasive bladder cancer. You really want to inspire confidence that the patient is getting the right treatment, and you have vetted the options, and everyone has kind of come back on the same page. So that's really, I think, a really important concept of this multidisciplinary team, is to really improve the confidence in the patient that they're making the right decision.
And that's really interesting. I'm interested to hear about how the patient will be communicated with. I'm wondering about the APP's role in this. Michael, do you have a very hands-on and direct communication with the patient? I'm thinking things like triage or education, talking to them about side effect monitoring and the follow-ups, that sort of thing.
Yeah, so I think like Dr. Park said, our group does a very, very good job of making sure when the physician goes in on that initial visit, I'm always there too. So they understand the teamwork approach that we're playing in this. And then, I make sure the patient is, especially in terms of the side effects, the education. If the patient's going to be undergoing surgery, I spend that 45 minutes to an hour preoperatively making sure they understand stepwise approach where this will be going. And then also the quality of life discussion is a huge thing I think that is just left out. Having that conversation early, making sure they understand the side effects of the medications that the oncologist might be talking about, and then also the operative side of this, and what kind of impact that's going to play in their life, as they move on. So as my role is, it's that transitioning from oncology back into the surgical world. I take that role with our group to make sure the patient's educated on what to expect.
Sounds like you're the glue in this MDT. The
I'm just
link,
the
the
safety
bridge.
net.
And I'm wondering, Dr. Park, from the oncology perspective, are there any communication gaps or timing gaps between the specialties that need to be addressed?
Yeah, I think the key is you have to have a clear path for the patient with a plan. And so when we kind of talk to the patient and we talk about neoadjuvant chemotherapy, we give them a calendar and we ask them, this is what it's going to look like with the chemotherapy and immunotherapy treatments. This is when we're going to finish treatment. And this is where we're going to start scheduling a follow up with Dr. J. Ram or one of the urologists. And so then the patients, they know that we have everything in place. And then we also mentioned that, the urologists that had referred to us, they're going to be kept informed of what's going on throughout their case. And that if they have any questions, to direct those calls to us. So that way the patients only have one place to call, because it could be very confusing for the patients. They're like, okay, what if I have this? What if I happen that? And then that's why I think our advanced practitioners and our nurse clinicians have a great job of getting these phone calls. And then I triage these phone calls. And that way the patients feel like they have a good communication flow.
And in those decisions about the treatment and the strategy ahead, the National Comprehensive Cancer Network, the NCCN, has guidelines. So, again, Dr. Park, how does that impact your approach to treatment decision making, given that the guidelines are there?
Yeah, I think it boils down to in the U.S. A lot of it reimbursement. I mean, I think with the NCCN guidelines, you definitely want to have treatments that be reimbursed. I think that's the most important. But the second thing is there's always new information that are not in the NCCN guidelines, such as checking circulating tumor DNA, which I do for my patients after cystectomy, because then I know which patients are in trouble if they're positive ctDNA. So yes, it is a guideline, but I still use my own information by reading information. I share with the patients and say, okay, we got to start using the ctDNA after surgery, and it may not be in the NCCN guidelines. Now, in terms of the treatments, you look at the category 1. You have some treatments that are not shown overall survival in a phase 3 study, and so I prefer to have category 1 treatments because there's a highest level of evidence.
And then again, I guess this is again following up for you, Dr. Park, about the balancing that decision. You talk about the cystectomy, the taking out of the bladder. How do you balance the decision to go ahead with a radical cystectomy or bladder preservation in some way, especially where you've got borderline cases?
Yeah, the question I have, and the very first question I have is this person medically fit, right? Are they 80 years old? Is their performance status very weak? If they're like an ECOG 2, maybe I don't really consider surgery in that instance, but I still have the urologist talk to them, because at the end of the day, I rely on the urologist to see if the person is a surgical fit. Then I start looking at the details. Do they have a solitary node? Do they have any CIS throughout the bladder? Do they have any tumor associated hydronephrosis? So, all of these things, if they're no, then I consider them a candidate for radiation. But I still talk to the urologist, like Dr. J. Ram, and say, Tom, what do you think? I mean, this person has like all of the features that might be a candidate for bladder sparing, but I never make that decision alone.
So, Dr. Jairam, how do you play into that decision, assessing eligibility and timing for that treatment?
Yeah, well, it's an experience game. It's a complicated question. All nails don't necessarily need a hammer, and this is where I think the excitement of the future is moving. Dr. Park talked about ctDNA. We're doing more with tumor DNA studies before we take bladders out. Our imaging is getting better. Our ability to characterize and stage disease with blue light cystoscopy. There's a whole lot of things that are really making this process easier. But big picture, the way I look at it, like Dr. Park said, are they surgically fit? Can I get them through the operation? Number one. Number two, if you want to talk about bladder preservation, do they have a bladder worth preserving? A lot of people miss that point. A lot of patients, after hosts of intravesical therapy courses, have very damaged bladders, and they're very, very bothered by their bladder. In that case, if they have persistent disease, it makes it a little bit easier to say, well, you know what? your quality of life will probably go up after a successful operation. The quality of life is fundamentally very important in the community. We have a hard time um, being, the that kind of final step that says you absolutely need to have your bladder out. That's tough. And as a very busy cystectomy surgeon, I can tell you that there are a lot of patients who come to me, and the first thing they say is, "I'm not having my bladder out." And that's an important part of the discussion, because then we talk about quality of life and we talk about reasons why. And some of those patients end up saying, "Okay, well, if it makes sense, we'll do it." But fundamentally, it is such a big operation that patients need to be involved. We use that term shared decision making a lot now, and that's really important. But I think, as Dr. Park and Michael would agree with me, a lot of this is just a good discussion with the patient. A lot of these patients say, "What would you do? What would you recommend? What would you do to your own father or mother?" It's on us to really talk to the patient and give them the information. Don't necessarily make their decision for them, but like Dr. Park said, there's a couple of principles that are really important. What's their ability to receive chemotherapy? What's their ability to tolerate an operation? Do they have a bladder worth preserving? And those of us that do this a lot, I think, understand that, those things are kind of where you start.
And Michael, do you take part in those discussions, helping to counsel the patients about those big decisions to have the bladder out or ask for other treatments?
Sure. Yeah, no, 100%. I mean, and that's where, I mean, you call it a burden, but it is one of those, the tougher conversations, the longer tenured conversations with the patient and the family. And I'm always try my best to make sure that a family member's also available, because it's not just the patient, it also affects the, surrounding family. And so many times I'll Zoom call in a son or a daughter into the conversation so they understand exactly, because again, like Dr. J Ram said, that shared decision making is not just between the clinician and the patient, it's also between the patient's family and how this is going to affect them as well. So I think that that's one of those things in the past 18 years since I've done this, that we kind of pushed to the back burner 18 years ago. We're trying to do a better idea and a kind of a talk track with the patient and the family. And then also, like Dr. Park had said, there are multiple modalities now. I mean, as cancer treatment has changed in the last 5 years. We have so many things that we can show the patient. And I tell a patient, look, just because you're diagnosed with, a muscle invasive type bladder cancer, this is not a death sentence. Many patients will live 10, 15 years. I have many patients that have been 15 and 20 years out. And so you've got to make sure the patient understands, give them hope, have them understand what those options are.
And then post cystectomy, if that surgery does go ahead, then Dr. Park, how do you then choose between the adjuvant chemotherapy and immunotherapy, based on the pathology or the patient factors there?
Yeah, just to go back a little bit, there's a lot of new information that's coming out. But, when we talk about patients for neoadjuvant, if they're cisplatin eligible or if they're cisplatin ineligible, we used to say, patients that are cisplatin eligible, we should consider them neoadjuvant chemotherapy. And if they're cisplatin ineligible, maybe we should just go straight to surgery. But, there's going to be a new study coming out called EV303, which is enfortumab vedotin and pembrolizumab for patients that are cisplatin eligible. And the news release is going to be positive. And so there are some patients that are considered cisplatin ineligible that's going to be considered for neoadjuvant treatment. And so that's one. Now, in terms of the patients that actually have a cystectomy, how do you choose between adjuvant chemotherapy and immunotherapy? Right now, the standard of care with the only one with the overall survival is the Niagara protocol, which is a perioperative sandwich treatment with chemoimmunotherapy with 4 cycles of cisgem and durva, cystectomy, and then 8 cycles of durva. Now, for whatever reason, if they did not get that treatment, then it boils down to, we got the InVigor11 coming out with the ctDNA that's going to be coming out next month. What is that data going to look like? But right now, we would have to say, even though there's no overall survival, the question is, have they received neoadjuvant chemotherapy alone? If they received neoadjuvant chemotherapy alone and they had a cystectomy And if they have a T2 or T3, then we would consider 1 year of nivolumab. But I would look at the PDL status. If the PDL status is great, greater than 1%, those are the patients that respond. It's very nuanced, but I think it really boils down to not everybody needs adjuvant nivolumab. Only the patients that have T2, T3, and N1 positive.
And I'm sure for all of you, an important aspect then is with the immune-mediated adverse reaction monitoring and management of that. So, Dr. Jairam, what strategies does your practice have for monitoring adverse reactions?
Yeah, it's a good question. I first just want to say, you can see how complicated by Dr. Park's answer. I mean, it's a great answer, but you can see how complicated this space is, and really serves to circle back and reinforce why you want experts at all positions on the football field here. But what our group has kind of pioneered the charge in superficial bladder cancer on giving checkpoint inhibitors. We do a lot of checkpoint inhibitor trials. And in 2017, we kind of started this approach where we were really interested in urologists being a little bit more than just kind of peripherally involved. And the reason is because we knew checkpoint inhibitors were going to be a big part of cancer care going forward. And now we can see that they are firmly entrenched in kidney cancer and bladder cancer. We have big studies, CREST and Potomac, coming out that are going to evaluate checkpoint inhibitors in BCG naive, which is early stage bladder cancer, which could potentially change the workflow quite a bit for both urologists and medical oncologists. So all of that to say is that I'm a firm believer that while urologists don't all need to be giving this, they all should be very, very well versed in the indications and the side effects. Basically, and Dr. Park knows this better than I. These immune-mediated events are kind of inflammatory events of any organ system in your body from head to toe. There are a certain kind of cadence of these in terms of timing and which ones occur more frequently. We utilize great APPs like Michael in our practice to give patients education, give them the treatment schedule, and then I kind of quarterback a team at our practice where patients get the treatments, and then we utilize telehealth visits, we utilize phone calls, inpatient or in-person visits to check laboratory imaging results to really keep a close eye on these patients. And so there's a lot of resources out now. Dr. Park, I'm sure, can expand upon those in terms of guidance for how to manage some of these immune-mediated adverse events. But the last thing I'll say is it really goes back to that relationship. When you have someone like Dr. Park in the community and you have a great relationship with that person, it really helps all the ships move a little bit faster in terms of I can make a phone call and say, hey, we're having a little bit of problems with the thyroid levels on this patient, after giving this treatment. What would you do at this point? Again, we've had a really good experience, and by no means are we the experts in giving these therapies, but we certainly, I think, with a good team and good coordination can do this and be on the front lines.
So, Dr. Park, what do you like to add to that?
Yeah, I agree 100%. I think with the immune therapy associated toxicity, all eyes on deck. Everybody has to look for different things. It's very subtle. Things such as thyroid disease. I mean, all patients after cystectomy are tired, right? But you have to check that TSH and free T4. If the TSH is above 10, free T4 is normal. Start that Synthroid at 50 micrograms. Get that ball rolling. And then if the blood pressure is low, then you check that 9 a.m. cortisol level. That seems to something I found a lot of patients with adrenal insufficiency there. And the endocrinologists, they don't have the urgency like the APPs and the urologists and the oncologists that treat patients with immunotherapy. You put in a referral there, it's going to be 3 months from now. And so you always start them with, hydrocortisone, 15 milligrams in the morning, 10 milligrams in the afternoon. Get the ball rolling, send the patient to the endocrinologist, and then they put a green stamp on it and say, okay, good job. But I think these are the things that I look at: the adrenal cortical insufficiencies, the thyroid, the rash. And the one thing is the diarrhea you don't want to miss. Because if the immune therapy causes like more than 8 or 9 bowel movements in a day, and the Imodium doesn't touch it, you got to do prednisone 1 milligram per kilo for 6 weeks and do a taper.
So, Michael, as an APP, how do you help to alert the other clinicians to those subtle signs that might be coming through that could be immune-related adverse events?
Yeah, what Dr. Park was saying, I mean, it's huge. The patient needs to understand the importance of labs, and what that can kind of, if you want to say, peel back the layers of problems, and telling the patient too, after surgery, hey, we're going to be doing X, Y, and Z therapy. Oncology will be managing this, but I'm still going to see you back in clinic if you're having, you know, urgency with an issue. Mainly GI is the one thing that I see, post immunotherapy type responses, making sure those things are not just, brushed under the rug, making sure those patients are coming in, you're asking the questions, you're looking at those labs, because Dr. Park's not wrong. Trying to refer over to an endocrinologist takes us 6 months to get in. We'll hit those labs now. We'll get those labs back within 24 hours. I can immediately call the patient, make sure they get over to the oncology, office, or in some instances with pulmonary type responses, I'll get that patient into an ICU immediately, have a CT scan done. I have a team, of intensive care specialists that are pulmonologists that I can call immediately overnight and say, hey, I got a critical lab value. We need to get this patient in. I need a CT scan on this patient now. We're having shortness of breath. Dr. J. Ram's APP, Aaron, he and I have a network of APPs across the country where a lot of times we'll do, an every other week call or text chain about, hey, we're having this problem. This response rate is nuts. I haven't seen this before. Have you seen this in your practice? But it's an understanding again of a teamwork approach, because one individual silo can't treat this. I mean, it is a definite community treatment type pattern. So, I think it's very, very important not just to blow off these different grades. Grade 1 can, eventually lead to grade 3 within 2 to 3 weeks, and making sure that the team is, with me as an APP, understanding that, making sure you're educated on what to treat and what to tell the patient.
Oh, that's interesting. It sounds that the team isn't just each of your individual specialties, but you're networking to other hospitals, to other areas to learn those best practices and bring them into your own regimens. And Dr. Park, do you have any mitigation strategies that can help reduce any serious adverse events while you can maintain the efficacy of the treatment itself?
Yeah, absolutely. I think whenever we have any kind of new nurse practitioners or nurses, I give them like a 1 page sheet that talks about, like, for instance, liver enzyme. We can memorize 3 versus 5 times, but it's easier to remember 100 and 150. So if it's a AST ALT above 100, that's a grade 2. 150, grade 3. So that's when we have to hold. So I do like a quick cheat sheet with the thyroid, the AST, ALT, number of diarrhea, more than 6. And that way, and then I kind of ask them if they have patients, and then I kind of see how they're doing. But then I try to give them a little bit more leeway. But I think that's the way, is to kind of educate the people around you, the nurses, the advanced practitioners. And so that way, because you can't be there everywhere, I think a lot of it is to educate the people around you as well.
Well, you've all covered so much ground. It's absolutely fascinating. But I wonder if I can pin you down to perhaps one key takeaway that you'd like people to remember from listening to this podcast. Something that, looking ahead, is an important message. Dr. Jairam, what would you say?
Well, I don't want to sound doom and gloom, but again, this is a dangerous disease state. Muscle invasive bladder cancer is a scenario where patients die. And Dr. Park and Michael know this. Even if they get timely treatment, a reasonable number of patients within 5 years will have metastatic spread and could have death from disease. So it's fundamentally very important to build or operationalize a process around these patients where they're not being treated by an isolated physician or someone who doesn't have a whole lot of experience, especially if you have a practice with a lot of resources. So fundamentally, building a multidisciplinary tumor board, building a network of multidisciplinary providers, vetting challenging cases or complicated cases amongst a group of experts, and then again, keeping really wide lines of communication between every touch point, I think, is a great kind of way for me to think about this, in terms of maximizing your outcomes. And really, for me, don't be scared to ask for help. And that's something that, as a surgical oncologist, we always say to junior surgeons when you're in the operating room, don't be afraid to ask for help. But I think everyone would agree it's very true in all aspects of cancer care. There are things that you will not recognize. There are things that may be a little bit odd. And that's where you have to kind of crowdsource to see what the best practices would be.
Thank you. And Dr. Park, what are your key takeaway thoughts?
Yeah, I think for the patients, whenever they see somebody, whether it be a urologist or medical oncologist, because even if you have stage 4 urothelial cancer, they have to have a team, right? If the patient has hydronephrosis, a medical oncologist cannot do that. So I think when you first meet that physician, ask them who's part of their team, because it's going to require a lot of different physicians helping them throughout the course. It's not going to be one person. And also, Dr. Ray J. Ram brought this up, is you have to manage people up, right? Patients are scared. They're going to have some adverse reactions, even if it's a good outcome, because of the side effects of the treatment, side effects of the surgery. So you just have to reassure them and say, Dr. J. Ram is an outstanding urologist, right? APP, he's a great APP. You just have to manage people up, because a lot of the patients are scared. You just have to comfort them. There's a lot of psychological and mental stuff that you just kind of relax and help the patients with.
And Michael White, PA, what would you say you'd like clinicians and those listening to our podcast to take away from this?
And I think with the evolving nature of the treatments, again, what Dr. J. Ram said, it's a very heavy diagnosis. You as a clinician, you've got to make sure you're staying up to date on these new modalities, making sure you're reaching out, like Dr. Park said, to the surrounding team. You can't do this by yourself. It's so important, especially from an APP standpoint, making sure you know your limitations and making sure you make those calls, making sure that you're following up when you're supposed to be following up, making sure the patient has an understanding. I call it a playbook for the patient, making sure they understand what those expectations are for them after surgery. It's not just end date of surgery. It's, I tell them, you're going to see us, very frequently, and making sure that they understand what your plan of care is for them. So I think from an APP standpoint, it's really taking a better effort in understanding the treatment modalities, because they are changing. It's very complicated. All these immunotherapies that are coming out now, making sure that you're staying up to date with the oncology team and how those patients are going to be treated once they go out your door into the oncology door.
Well, thank you all so much to Michael White, PA, to Dr. Chandler Park and Dr. Tam Jairam. You've given us so many fascinating insights into how multidisciplinary teams can work together to provide optimal care for muscle-invasive bladder cancer patients. I've loved the discussions. Thank you so much for joining us.
Thanks for having us.
Thank you.
Oh, thanks, guys.
And for our audience, you can find further podcasts and videocasts on a wide variety of medical topics by going to emjreviews.com or subscribing on whichever platform you find your podcasts. So from me, Sue Saville, and from the AMJ, thank you for joining us. Goodbye for now.